Good morning, good afternoon, good evening, everyone. I'm Carlos Cáceres. I'm coordinating this session. This is one of the three special sessions programmed by NEMUS around World AIDS Day. You may remember World AIDS Day is the 1st of December, so 3 days from today. And this is the second session. We are focusing this session on the recent HIV R4P Conference, which took place in October in Chicago. And as people know, this is one of the most important research conferences where HIV prevention in particular information is presented. Probably CROI includes both prevention and treatment and basic science, and R4P is more clearly focused on prevention. So this is an important conference for people working in ARV-based prevention and other innovations in HIV prevention. So we are honored today to have Dr. Raphael Landovitz, who was one of the rapporteurs in this conference, present a summary focused on ARV-based prevention and PrEP research. And I can say a few words about Dr. Landovitz. He was trained at Princeton University and Harvard Medical School. He completed postgraduate training in internal medicine at Brigham and Women's Hospital, and infectious diseases and HIV medicine at Brigham and Women's Hospital and Massachusetts General Hospital. He served as chief medical resident there, and then as medical co-director of the Vietnam CDC-Harvard Medical School and its partnership. At present, he is associate professor of medicine in the Division of Infectious Diseases at UCLA, associate director of the UCLA Center for Clinical AIDS Research and Education, and co-director of the UCLA Center for HIV Identification, Prevention, and Treatment Services, CHIPTS. So it's my pleasure to introduce Raphael today, who has been kind to share that important information today. And Raphael will speak for, I don't know, he's free to speak for a half hour or 35 minutes, 40 minutes, and then we'll have the opportunity at the end to look at some questions. Please use the window, the chat window in the system for your questions or comments, and we'll look at them at the end. Remember as well that this session is being recorded, and that the webcast is going to be uploaded and to our YouTube channel and to our website later today or tomorrow. So again, Raphael, thanks a lot for being here and welcome. Please go ahead.
Thank you, Carlos. Thank you for inviting me, and thank you all for joining. I know across the world the timings are sometimes very early in the morning and sometimes very late, so I appreciate everyone making the effort to be on. As Dr. Cáceres was saying, I was one of the rapporteurs at this year's R4P conference, and some people are less familiar with the R4P conference. It's a fairly new conference. It's sponsored by the NIH and other partners, and was designed to bring together the former meetings that would individually focus on NIH-sponsored vaccine research, NIH-sponsored microbicide research, and other NIH-sponsored prevention work into one synthesized conference. And the first one was held in 2014 in Cape Town, and was a tremendously successful meeting. And so this is the second one. It's every other year. As Dr. Cáceres mentioned, it was in Chicago from October 17th to 21st. And the 2018 conference just recently announced that it will be in Madrid, also in the fall of 2018. For the conference this year, the rapporteur duties were divided into 4 broad categories. There was a basic science group, there was a vaccines group separate from that basic science group, there was an ART group that I was in charge of, and then there was a cross-cutting group which focused on issues that went across those domains or encompass things that were not necessarily covered in those other 3 groups. And I have to say, for me, what was tremendously exciting about this conference was the presentations about implementation science and about community engagement around all 3 of these areas. Those are areas that historically have gotten less attention at some other conferences that are focused more on basic science, but this conference, as the IAS conference does, had a very strong social science and community engagement and implementation science component, which made it tremendously exciting. So by way of disclaimer, this presentation is going to largely focus on the ART-based prevention modalities. I'll briefly talk about some of the plenaries that were more cross-cutting and a couple of abstracts that I thought were particularly worth mentioning to people who are interested in ART-based HIV prevention, but largely I'm not going to be addressing the basic science and the vaccine work that was covered. I'm happy to try to answer questions about it, but I did not have a chance to personally see a lot of those presentations because I was sort of very focused on the ART information. So with that preamble, I'm going to try and advance my slides. There we go. Antiretroviral therapy, we call it ART. I would also like to remind people that since the conference was in Chicago, there was some other art to be seen, and this is my favorite painting that is hanging at the Chicago Institute of Art. It's, of course, Sunday Afternoon on the Island of La Grande Jatte by Georges Seurat. Personally, I could stand there and look at this painting for hours, and I have been known to do that. But anyway, the conference opened with some really outstanding plenaries that were very cross-cutting. And I want to talk about them a little bit, not necessarily because there was new science presented, although there was some fascinating new science presented in the context of these plenaries, but really because it framed the conference incredibly nicely. And the first one that did that was Mike Cohen, who of course is known to many on this call as the PI of, the co-PI of the HIV Prevention Trials Network, and also the lead investigator of HPTN 052, the study that definitively showed in a randomized controlled trial that treatment of HIV-infected partners in serodiscordant relationships dramatically reduces the horizontal secondary transmission of HIV when those patients are on treatment and undetectable. So Mike presented a really nice overview slide of where we're going with prevention and reminded us with this slide that he's shown in the past in a number of other contexts about the numerous opportunities for HIV prevention, and they really span 4 distinct periods of time and categories of individuals. On the right, of course, is the group of people that Mike has studied in the most detail, HIV-infected individuals, and as I mentioned in HPTN 052 and now other studies shown that treatment with ART to virologic suppression of HIV-infected individual has dramatic reductions associated with it of onward secondary transmission, and that can affect people over the span of their HIV-infected lifetime. He then went on to remind us that people who are HIV uninfected, which are the remaining 3 categories, but have been exposed already, have a number of intervention opportunities. And those, of course, might include still a vaccine and ART-based post-exposure prophylaxis, or PrEP. And although most guidelines attribute a window of efficacy for that sort of intervention to be about 72 hours, I think that's a fairly liberal estimate. And I think most people who study this phase of HIV acquisition think that there may be a frighteningly narrow window after an exposure with which to deploy a post-exposure strategy and have it have efficacy, with some animal models suggesting that as quickly as 8 hours after an infection, that window may no longer exist. Obviously, because no one knows that definitively, we have those guidelines for the most part suggest a 72-hour window for consideration of such an intervention. Of course, HIV uninfected individuals before they're exposed have a number of interventions which might be efficacious. Obviously, the holy grail would be a protective vaccine. We've heard a lot over the past 6 or 7 years about ARV-based PrEP, and we're going to continue to hear more about that, I think, in the near to longer term future. Microbicides being a topical version of PrEP, monoclonal antibodies that is essentially trying to cut out the stage of a vaccine and jumping right to the production of broadly neutralizing antibodies, which might not only inform vaccine design, but one day have a formulation that could be administered in and of itself as a prevention opportunity modality. And of course, we have a wide variety of non-biomedical prevention opportunities that we've known about longstandingly and have struggled to have population-level incidence impact by deploying and scaling up. And these include behavioral interventions, structural interventions, treatment and diagnosis of STDs, circumcision, which has had some new exciting breakthroughs in the ability to scale up such activities, and of course, condoms, which are the best studied biomedical prevention modality, if you will. So with that context, Mike really nicely set the stage for a presentation by Tony Falchi, who of course is the head of the NIAID Institute at the NIH in the United States. And Tony presented some very exciting and promising work that has derived largely from work done in his lab, but also others. And I just want to prepare people that this is as basic science-y as I'm going to get in this talk, but as it was a plenary, and Tony's excitement about this field of study is tremendously contagious. And when he talks about it, you can't help but catch some of his enthusiasm. So Tony's lab has been investigating a cellular surface protein called alpha-4 beta-7, and this is an integrin. And what he's been interested in particularly are monoclonal antibodies that are directed at this alpha-4 beta-7 antibody. And he showed some basic science that supports that this might be helpful in either prevention primarily, or the area that's been studied the most in HIV or SIV, for a simian model, infected individuals, that it might be a target for a functional cure. That is, that if this anti-alpha-4 beta-7 antibody were to live up to its promise, that HIV-infected individuals, or in this case SIV-infected monkeys, might be able to control their viremia at near undetectable levels without antiretroviral therapy. And what he showed was a macaque experiment that is a little bit complicated, but it's depicted in this graphic that's on your screen now. And if people are having trouble seeing the graphics in the slide, please interrupt and let me know, or send a chat message so that we can try and fix that, because a lot of these slides are going to have graphics that I'm going to sort of orient people to. So this was a macaque challenge experiment, and you can see phase 1 is when these macaque monkeys were infected with a strain of SIV called SIV MAC239, and it was administered intravenously at very high titers with a goal of infecting these macaque monkeys. And then starting 5 weeks after that infection was established, and it was established by measuring SIV viral load that all these animals had become infected with SIV, they were given antiretroviral therapy, and it was shown that the viremia that these monkeys had was able to be suppressed with antiretroviral therapy, much like in humans who become HIV infected are viremic until they're administered antiretroviral therapy, with few rare exceptions, of course. Starting 4 weeks after the beginning of the antiretroviral therapy, the macaque monkeys were split into 2 groups. 11 of the monkeys received this alpha-4 beta-7 antibody, and the remaining 7 monkeys received intravenous immune globulin, so essentially an antibody control, but not one that was specifically directed at alpha-4 beta-7. And that was given as a number of infusions. And at the week 18 time point, so 13 weeks after the ART was started, while the antibody infusions, either the anti-alpha-4 beta-7 or the IgG infusions, were continuing, the ART was withdrawn. So in other words, this is the analog of a therapeutic treatment interruption in humans, but the antibody infusions were continued. And they were continued for another number of weeks, and then by week 32, all of the infusions stopped, and the animals were followed for a number of additional weeks. And this is a lot of words on the next slide, but what he saw was fascinating. The animals that got the alpha-4 beta-7 antibody together with the 90-day course of ART after they were infected allowed those animals to maintain virologic suppression even when the ART was withdrawn. That was not true of the animals that were in that control group and received the IVIG antibody infusion as opposed to the anti-alpha-4 beta-7. There were a number of immunologic studies that were done that were also extremely exciting, associated with alpha-4 beta-7 virologic maintenance after ART was withdrawn. CD4 positive T cells were restored to the gut, blood, and peripheral lymphoid tissue. So there could be immunologic consequences that are exciting about this, not just control of viremia. And what's most curious, really, about this is no one really has any idea what the mechanism is of this monoclonal antibody against alpha-4 beta-7. And you might say, and you'd be right, well, that's fascinating, but that's a macaque monkey study, and we've seen a number of macaque monkey studies that have been extremely promising, and then when the product or the intervention has gotten into humans, they've not worked. So I think we've all been on a roller coaster ride of being very excited about a macaque intervention that looks promising and then not had it borne out in humans. So the real question is, will this work in humans? And the exciting news is we're going to know soon. It turns out there's a product that's already US FDA approved that is an anti-alpha-4 beta-7 monoclonal antibody. It has the name of vedolizumab, and it's currently FDA approved for treatment of inflammatory bowel disease, so ulcerative colitis and Crohn's disease. And so what Dr. Falchi's group is now doing is somewhere between 15 and 20 patients, they're negotiating with the US FDA, are being studied in a single-arm, open-label study of vedolizumab in HIV-infected individuals who are long-term suppressed on antiretroviral therapy, with a plan of giving them the vedolizumab and then withdrawing their antiretroviral therapy and watching them extremely carefully for signs of virologic rebound. The first patient was entered into the study in August of 2016, and they're hopeful that these 15 to 20 participants will be enrolled quickly and that we may have data as soon as in the spring and possibly even by Paris IAS meeting this summer. So stay tuned for more about that. It's tremendously exciting, although the mechanism of how this works is unknown, but is an area of great interest for study and to see if this works in humans. Another plenary, which was tremendously exciting at the R4P conference, really opened my eyes to the power of phylogenetics and phylogenetic mapping of HIV virus. And of course, the principle of this is the idea that every time HIV replicates itself, it causes errors in its own genetic material. So if you have sophisticated molecular genetic techniques, you're able to essentially tell how many generations have passed from a parent virus to a baby virus if you are able to figure out the differences in genetic material from one to the other. It essentially sets up a very precise molecular clock. It also helps to identify the source virus in transmitted infection because of genetic similarities or absence of genetic similarity. And Dylan Pillay presented some really elegant work that tried to shed some insight into the results of the ANRS 12249 TASP study, which was presented at the IAS conference this past summer in Durban. If everyone remembers, that study looked at an intervention of early ART treatment for HIV-infected individuals compared to a control condition of ART initiation, trying to look at population-level incidence impact of the strategies and fully expecting to see a reduction in population-level HIV incidence afforded by the early ART intervention group. And of course, that was not seen. There was no intervention effect seen, and people are puzzled as to why that might be. So using some molecular clocking techniques, what's been able to be teased out is although the UNAIDS and WHO targets of 90% of individuals diagnosed, 90% of those diagnosed on treatment, and 90% of those on treatment virologically suppressed, ultimately leading to 72.9% of all those HIV infected virologically suppressed, would have been able to achieve important targets, showing a difference in that study, that those goals were not achieved. And where those 90-90-90 numbers broke down, again assessed using these molecular clocking techniques, was a large fall off between those diagnosed and getting on treatment. You can see that in the ANRS study, more than 90% of those who were infected were diagnosed, so only between 45 and 50% of those diagnosed were able to be started on treatment. But of those who were started on treatment, more than 90% were able to achieve virologic suppression. However, that enormous discrepancy between 90%, that was the goal of getting those diagnosed on treatment, was seen in the study. That's why only overall virologic suppression rates of 40 and 42% were able to be seen. And it really emphasizes that using these molecular techniques, we can see where some lesions are in the care and treatment cascade and direct some locations for further intervention, and also remind us that while HIV antiretroviral treatment has tremendous power, if taken, to reduce ongoing transmission and reduce new infections, there are some important reasons that need to be really clarified and intervened upon about why that is unlikely in and of itself to be a way to end the HIV epidemic. And that ANRS study really showed us why ending the epidemic with HIV treatment alone is unlikely to be successful, and why we need prevention interventions so desperately for HIV uninfected and at-risk individuals. Another really exciting study, particularly for the developing world in resource-limited settings, was presented that addressed the question of safety to newborn infants who are breastfeeding and their mothers are taking PrEP for HIV prevention. So these are HIV uninfected mothers who either have an HIV-infected partner or partners of unknown serostatus. And this was a sub-study of the Partners Collaborative where 50 HIV uninfected mother-infant pairs were administered directly observed oral PrEP to the mothers. And the mothers received TDF-FTC for 10 consecutive days and then had peak and trough levels sampled at day 7 and 10 for their plasma. And they also had breast milk samples taken as well. And the infants, who are also HIV uninfected as they were born to HIV uninfected mothers, had random plasma drug levels after the 7th day of dosing assayed to see if they had any exposure to the components of the TDF-FTC. So we're able to prove, number one, because of directly observed therapy, that the mothers were taking the drug, and number two, through biochemical assays, that they were absorbing it, and there was drug detected in the plasma of the mothers and in the breast milk, and then they measured the drug levels in the infants. And the long story short from this abstract, and remember this is an uncontrolled cohort, and it's small numbers, it's only 50, but the drug levels that were detectable, both in the breast milk, but more importantly in the infants, were negligible. So based on this, and this is not a safety study, this is not clinical outcomes, this is simply pharmacokinetic measurement of drug levels, the argument that women who are breastfeeding should not take TDF-FTC because of concerns of exposure of the infant who may be breastfeeding do not appear to be supported sufficiently to argue that these HIV uninfected women who could be using PrEP to keep themselves HIV uninfected should not do so. In other words, this is supportive of HIV uninfected mothers who may be ongoingly at risk for HIV seroconversion. It seems like it would be safe to their breastfeeding infants to take PrEP. There was some interesting data presented in follow-up to the MTN-020 ASPIRE trial, which of course was one of the 2 phase 3 efficacy studies presented at CROI this past year of the dapivirine ring in HIV uninfected women in sub-Saharan Africa. It showed approximately a 30% overall efficacy compared to placebo for HIV prevention. And a lot of people were concerned about a number of things about a dapivirine ring. People were concerned that a vaginal ring wouldn't provide rectal protection for women. It wouldn't provide systemic protection. And in particular with dapivirine, people were concerned that the use of a non-nucleoside reverse transcriptase inhibitor-based PrEP, if failed, that is, if the individual became HIV infected in the context of its use, might then have NNRTI-resistant virus, making it much more difficult to treat with first-line regimens, particularly in resource-limited settings, where efavirenz or other NNRTI-based therapy is still first line. So this analysis of the seroconverters in MTN-020 ASPIRE was trying to assess if the rate of mutations in seroconverters was different in the women who were randomized to the dapivirine ring versus the placebo ring. And what you can see here is the rates really were not different. There was 1% K103Ns in people who seroconverted on the placebo ring, and 3% in people who seroconverted in the dapivirine ring. There were some other minor mutations associated with NNRTIs also that were seen, including the E138A mutation, but you can see those were actually more frequent in the placebo ring-treated individuals than the dapivirine ring-treated individuals. So one question that came up in the discussion of this abstract at the conference that was very interesting, of course, was the primary ring ASPIRE result was, I'm going to use a term that many may relate to here, was iprexian, right? The first iprex results were somewhat disappointing in the overall point estimate of 44% protection for active systemic TDF-FTC versus placebo, but the devil was in the details, right? It was all about adherence to the study product, and the ring study seems similar, right? It was 30% overall efficacy, but there really seemed to be a correlation with adherence to the dapivirine ring as measured by residual drug left in the ring when the ring was removed at the end of the month. So one question that came up for discussion when these data were presented, which were billed as encouraging that people who seroconverted through the use of a dapivirine ring did not have NNRTI-resistant mutations, was there sufficient use of the ring to actually feel that this result is significant and robust? In other words, did people not seroconvert with NNRTI-resistant virus because really dapivirine doesn't cause that, or did they not seroconvert with NNRTI-resistant virus because they weren't using it enough to put selective pressure on seroconversion with those quasi-species? So that question remains to be answered, but these are at least the most promising data we could have hoped for. Obviously, if we had seen the opposite, it might have been very concerning for the ongoing open-label trials of the dapivirine ring in sub-Saharan Africa, which are currently continuing now. The next abstract I want to tell you about was something that actually was very disturbing and very frightening, and I thought it was one of the most fascinating presentations in terms of social science that we saw at the conference, and it was presented by Sarah Calabrese, who was at Yale at the time she did the work. She's now at George Washington University in Washington, D.C., and she surveyed U.S. medical students. So it's important to remember that these are medical students who have not yet had a chance to practice, they're not yet licensed, but she was interested in their thoughts on pre-exposure prophylaxis use and who these medical students would be most likely to prescribe PrEP for. And again, I really want to caution people that these are people who have never prescribed anything on their own to anyone ever. So this is a completely hypothetical study. And I'll ask you to look on this slide at the panel on the left. And she presented a number of scenarios as options and asked the medical students if they would be willing to prescribe PrEP to these individuals. And so the yellow bars represent one scenario where these were MSM, and if they were in a monogamous relationship with an HIV-infected male partner who was not on HIV treatment. So I think we would all agree that that's a high-risk scenario overall, but the three categories in the bar graph are the plans that the participants, patients or hypothetical patients reported. So the top bar was if they planned to have sustained condom use, would the medical student want to prescribe them PrEP? And we can see is the overwhelming majority would prescribe PrEP for someone who was going to use condoms continuously. If someone said that they were not going to use condoms, you can see that the rates of willingness to prescribe PrEP drop off to nearly half. And if they had been currently using condoms but were planning to stop using condoms once they started PrEP, you can see that the rates fell off even lower to about a quarter. Scenario B, the blue bars, is also an MSM who is not in a monogamous relationship but instead has multiple male partners of unknown HIV treatment status and serostatus. You can see that the numbers sort of parallel but are lower overall than those with the yellow bars in the monogamous HIV-infected male partner scenario. And what's most interesting about this is the people who are most likely to benefit from PrEP and need additional HIV prevention are the people least likely to have been prescribed PrEP by these medical students. So this is fascinating, and the author interpreted this as indicating that medical students and likely providers in general have really strong biases towards condoms as the only acceptable method of HIV prevention. These are US-based medical students, and we don't have a lot of information about who these medical students were. Also interesting when Sarah found this was she was interested in noting the high levels of non-acceptance of non-condom use. And so she went a little further and explored with these medical students what they considered an acceptable reason to stop using condoms. And what she found was something what she called heteronormative. And you can see on the right bar of this slide that overwhelmingly the highest rates of an acceptable reason to stop using condoms were reported was if conception was the goal. Anything associated with intimacy or emotional connection, pleasure, or sexual functioning was much less likely to be identified as an acceptable reason to stop using condoms for these medical students. Now, I say that these data are frightening because I fear that they may also reflect biases of people who actually do have prescribing privileges and not only medical students, although we don't know that for a fact. The next abstract I want to cover was a second case of someone seroconverting to HIV despite sustained use of PrEP. People will remember at CROI last year, a case was presented of someone who became HIV infected with a multidrug-resistant HIV quasi-species despite biological markers in plasma, dry blood spots, and hair of sustained PrEP use. And there was a tremendous amount of interest around that. At R4P, we had a second case presented. This was someone who had very complicated HIV serologies to interpret. This was somebody who started PrEP, was ostensibly adhering to it, taking it every day. In May of 2016, they presented with a reactive fourth-generation HIV antigen antibody test and a positive qualitative nucleic acid test, so basically a qualitative viral load. A multi-spot was non-reactive. A quantitative viral load and Western blot were not done at that time. As soon as those results were obtained, the patient was brought back in, and at that time, again, the fourth generation and the qualitative nucleic acid test were reactive. A multi-spot was non-reactive. A quantitative viral load was undetectable, but was below 20, but signal was detected, and a Western blot was positive at GP160 and P55 with weak bands at 51, 41, 40, and 24. After those results were found, dolutegravir was added to the TDF-FTC, which had been continued to that point, and a follow-up Western blot done again at that time was virtually identical with minor changes in the weak bands of the Western blot. And then about 2 weeks later, the participant was brought back in and found to have a reactive fourth-generation test, but the qualitative NAT was now non-reactive, which was consistent with the quantitative RNA, no signal detected less than 20. The multi-spot remained negative, and the Western blot was identical to what it had been 2 weeks previously. Now, this is the second case of seroconversion despite regular use of PrEP, and again, adherence metrics were looked at with DBS and plasma samples, and it seemed, in fact, as if this individual were taking PrEP as directed daily. And what was found was a rare species that was resistant to both TDF and FTC with K65R and M184V. So again, I think there's a lot of interest in these sorts of cases, but I think the take-home point is considering the enormous number of people who to date have taken PrEP and likely been exposed to HIV, and even those who have seroconverted in the context of PrEP use, most often with inconsistent PrEP use. Nothing is perfect. Nothing is 100%. There are resistant quasi-species circulating around, and these are going to happen. And hopefully these will remain extremely rare cases, and therefore we will continue to analyze them in excruciating detail each time one of them comes to the table that is well characterized. Ian McGowan presented some really fascinating data on a natural product that might have a future as a microbicide or a PrEP agent. It's called Rampur, and this is an explant of frog oocytes. So in a rectal explant model of HIV infection, this RNA protease has shown dose-dependent inhibition of HIV infection and no cytotoxicity, which gives it some excitement for a topical microbicide. And it's currently FDA approved. Sorry, it's not FDA approved. It's currently in advanced stages of study for a number of different diseases in the United States, including genital warts and a number of malignancies. But because of this antiviral activity, and it was also shown to have activity against Ebola and Zika, among other viruses, there's tremendous excitement about this agent. These are extremely early in vitro and explant model infections with regard to HIV, so stay tuned for more about this chemical. You can be sure that the Pittsburgh group and others are going to be tremendously interested in this. Moving on to injectable PrEP, Susan Ford from the ViiV group presented some really provocative data, and I have to admit I'm biased in the reporting of this because I'm as many of you know, very heavily involved in the cabotegravir for PrEP development initiatives that the HPTN is doing. So I found this to be one of the most exciting and provocative presentations at R4P. But if people remember the ACLAIR study, which was presented by Marty Markowitz at CROI this past February, it was a phase 2A safety study of long-acting injectable cabotegravir in low-risk HIV uninfected men in the United States. They enrolled 127 men and randomized them 5-to-1 to active cabotegravir or a placebo. They gave them 4 weeks of pill version of cabotegravir or placebo to assure safety, and then gave a series of 3 injections of 800 milligrams of cabotegravir administered each every 12 weeks. And after that series of 3 quarterly injections, they followed everyone for 52 weeks after the final injection. And that was based on some phase 1 data that suggested that long-acting injectable cabotegravir could last as long as 48 to 52 weeks after the final injection. And Marty at CROI presented the primary data from ACLAIR that showed that based on the prophylactic drug level targets that we had developed from macaque models of rectal HIV prevention, every 12 weeks wasn't going to be, it was too long. The drug didn't last for 12 weeks. And so for that reason, additional work was embarked on using an every 8-week interval that looks much better. And in fact, every 8-week cabotegravir injectable is what's going into the phase 3 studies that are going to be starting soon. But what was new at R4P was they presented the 52-week tail phase data from the ACLAIR study. And previously, I'm going to ask you to look at the bar graph that's on this slide. I'm going to ask you to look at the blue, well, first the orange bars. We have been told that 100% of people would go to not quantifiable by 48 to 52 weeks after the final injection. And the x-axis on this graph is number of weeks after the final injection. You can see that that only gets up to 83%. And if you look at who does not get to undetectable by 48 to 52 weeks, it's around 17% of people. So that's almost a fifth of people were not undetectable by a full year after their final injection. So that's the new information, is that the PK tail may last a little bit longer than was previously thought. And when pressed, Susan Ford was asked to estimate how long she thought it would take for those 14 subjects to become undetectable. And that ranged anywhere from an additional week and a half to an additional 38 weeks. But that 38 weeks was an outlier, and the next longest would have been about 18 weeks. So for that reason, people are wondering if a better approximation, at least in men, of how long cabotegravir might last after the final injection might be up to 1.5 years rather than just a year. But the important thing to remember is still the overwhelming majority of people had undetectable levels much earlier actually than a year off. You can see 35% had undetectable levels at 24 weeks. Again, we're looking at the orange bars, 70% by 36 weeks, and 83 and 84% by 48 to 52 weeks. Okay, so that's all I want to say about that. Al Liu, and I'm going to go quickly here because I don't want to leave no time for discussion and questions at the end. Al Liu presented some baseline data from his EPIC study. EPIC is an adherence support intervention study for open-label daily oral TDF FTC focused on young MSM in the U.S. It's being done in Chicago. And what he was able to show, he's not shown the intervention results yet because the study is still ongoing, but he did look at the DBS levels overall in the study and was able to identify some predictors of who was going to have protective levels. And this is consistent with what has been seen in other studies of US-based PrEP users, that African-American MSM were less likely to have protective levels than other racial and ethnic groups. It seemed like insurance status was also highly predictive of having protective levels. So again, highlighting populations in whom structural, financial, social barriers really need to be addressed before we're going to be able to really get the benefits of PrEP that we think we could have for HIV prevention. When in the Partners PrEP study, there was some really interesting data looking at whether the use of PrEP changed over time for HIV uninfected women in Kenya and Uganda. And when looked at by a number of different adherence metrics, the question was, what happens over time to adherence and what is the level of adherence that is used? And this is particularly interesting in light of Angela Kashuba and Mackenzie Cottrell's data suggesting that 6 or more doses per week of TDF-based oral PrEP would be required to get cervicovaginal protection. And you can see that the average use did in fact hover right around the 6 doses per week adherence over time, but for women under 25, the adherence tended to go lower and was more erratic. So again, indicating a target population where we need to focus adherence maximization strategy if in fact it turns out to be true that these higher levels of adherence are required for cervical vaginal protection as opposed to rectal protection. Dawn Smith presented some sobering data about U.S. health departments identifying that only 38% of local health departments in the United States are engaged in PrEP implementation, and frustratingly, the ones that are most engaged in PrEP implementation are not the areas of the United States where the epidemic is most concentrated, that being the southeast of the United States. So clearly some work needs to be done with US-based health departments if PrEP is going to be scaled up as part of HIV prevention strategies. We saw some very interesting data from San Francisco about whether women who are coming into family planning clinics specifically for a reason associated with reproductive goals would be interested in learning more about PrEP at the location that they were seeking their family planning services. And the long story short was they really weren't. And remember, this isn't necessarily a fair assessment because they weren't coming in for HIV prevention services. They were coming in for a specified goal of addressing a reproductive health care need. And this was theoretical. The services were not available, but very few were interested in learning more on that day about PrEP. And that held true even for people who, by behavioral risk criteria, met the CDC criteria for benefiting from PrEP. Doug Krakauer from the Beth Israel Deaconess Hospital in Boston presented some interesting data of a clinical cohort. They have a large number of people at the Fenway Institute in Boston who are on PrEP, and they were looking at reasons that people had discontinued PrEP. And they found that a lot of it was due to insurance status or absence of good insurance, that they decided to use NPEP at some point because they felt that PrEP wasn't protective enough for them. If there was a substance use disorder, if there were mental health disorders, if they were in a relationship status with an HIV uninfected partner, they were less likely to have sustained use of PrEP, and transgender women were more likely to have these unplanned discontinuations. Younger individuals also were more likely to stay on PrEP, but that was barely statistically significant. We had some very interesting results of the strategy in dapivirine ring studies of supporting adherence by giving site-level results back to sites about plasma dapivirine levels. So even though it was a double-blind trial, the dapivirine ring study were a registrational trial, there was interest in supporting adherence. So not at the individual level, because that would unblind someone, but site-level feedback was maintained and allowed sites to deploy site-based interventions. And they were successful at increasing overall rates of adherence throughout the study. So this is the first time in a double-blind, placebo-controlled study that real-time drug-level feedback was used successfully. And this is the last thing I want to mention. There was a poster that was very interesting. I think there's a lot of excitement about injectable PrEP. Again, I'm biased in this regard. I think injectable PrEP is going to be very exciting. And Katrine Myers and Sarit Golub from New York City asked MSM who were using daily oral PrEP if they would be interested in switching to an every 12-week injectable PrEP modality. And you can see the results here. More than a third definitely would switch. Almost 30%, more than 30% would probably switch. But there are very few who definitely would not switch, which is exciting and promising news for these injectable PrEP modalities. I'll stop there. I went way over time, and thank you for your attention. I'm happy to answer any questions for discussion.
Thank you, Raphael. I think it's been extremely interesting, and it's true we don't have a lot of time, but I guess there are a few things that well, at least I wanted to point out. First, the issue of the fact that the conference not only focused on research and new strategies, but actually there was some implementation research and well, even health systems, or you could say access. No, a good example of that, for example, is in fact the study on medical students, and I agree that it's really concerning. In fact, I wouldn't say it's an issue of students believing just that condoms are better. I think it's clearly moralism. Those are moralistic views that are typical in medical schools. Normally, for some reason, medical teaching ends up being quite moralistic in terms of sexual behavior, and I guess we have all seen that stopping to use condoms is considered something that is not appropriate. Also, and unfortunately, people who need PrEP most are those who are not necessarily using condoms. Well, people who need PrEP most, and students are doing exactly the opposite. Anyway, that's one point. The second point, I think you said it very well. The issue of this new case of infection identified despite good adherence. As you pointed out, the vast majority of infections will result from very low adherence. No, I'm not talking just about not ideal adherence, which is daily, because in fact we know that there's much. I mean, there's forgiveness, significant forgiveness, particularly for men, but really people who are extremely low who adhere extremely poorly, those who might get infected most often, and so the issue of finding somebody who has a resistant viral strain is really not so common, not so frequent. One question that because I remember making that question at the conference myself, regarding the relatively low achievement in terms of countries already using PrEP. I guess lots of the experience presented came from the US, and really very few countries can say they have ongoing PrEP programs. It's starting in many, well, the US and France. It's starting as a private initiative in many countries, to the extent people have access. But so I guess one question I would ask you is regarding what the perception at the conference was regarding the pace at which PrEP is becoming available in the various countries that would need PrEP around the world. No? So, and what are the obstacles for that? No? So that's one question. And since we don't have time, I would read another question that just came from Hamid Vega. Do trans women or were trans women less adherent because of substance disorders in the same way as MSM? So that's the second question that I can read here. And people are really thanking you for praising your presentation. Okay, I stop there.
Yeah, thanks. So briefly, I think we are seeing, and there's been data presented by Gilead most recently at the Glasgow conference, that there is an exponential increase in PrEP uptake, at least in the U.S., based on prescription records. The problem is it's not clear that we're getting PrEP to the people who need it most, to the most affected populations with the highest HIV incidence, that being young people, African American and Latino MSM in the U.S. So we're getting it in the hands of people who are better educated, better plugged into the healthcare system, and not necessarily to the people who are struggling with these barriers that we were talking about, the structural, economic, social barriers that prevent them from engaging in healthcare overall, and we need to do better with that. So yes, there's more PrEP uptake, but I'm not sure we're getting it to the right places, and I think it'll be very interesting to see how true that is in other countries also, whether we're getting it into the most at-risk subpopulations. Regarding trans women, I think the only data we know for sure is Maddie Deutsch's subset analysis of the IPREX cohort trans women. And I think we're going to learn a lot more. There are a number of demonstration projects ongoing, including a study in Peru that I know is ongoing, as well as a number of projects here in the United States that are going to much better clarify what the story is with the apparent reduced adherence in trans women. And I say apparent because we don't know if there are drug-drug interactions that could be reducing drug levels, or if there are measurement issues with individuals using cross-sex hormone therapy that reduce either drug levels for real or the sensitivity of these measurement techniques. So I think there's a lot to be still studied in trans women and well, there's no data in trans men to date. So I think it's really important that we get those data before we sort of categorize anyone as less adherent, because I don't know that we know for a fact that that's true yet.
Okay, excellent. Thank you. We'll have to stop here, but just I should just say that I was talking about the fact that very few countries have actually implemented PrEP programs or have decided they are going to either fund PrEP. That was the case in France, but it hasn't happened in the UK. I think some other countries in Europe are going to do that. I remember one Scandinavian country just decided to do it, but it's going to be difficult in many other countries because of price. And then, well, in other countries, I think you can access PrEP if it's available commercially and if doctors prescribe it. But in terms of publicly funded programs, just very, very few, or covered by insurance, very, very few countries. And that's, I mean, the obstacles for that and ways to overcome that limitation should be a focus of more efforts, more work, I think. Otherwise, we're going to keep discussing results from just a handful of countries, particularly the US, but it will continue to be sort of a theory in many other countries, and that would be a real problem. Anyway, in fact, just about this, our last webinar of the year and the third of this special series is happening next Monday at the same time with Jerry Galea. He's going to present preliminary results of his study on PrEP in the wild, exactly about people who access PrEP on their own using, I mean, all kinds of strategies, and that's going to be very interesting, I think. And it's really, what we're really missing is a serious policy discussion about I mean, important steps needed to really move towards increased access. Anyway, again, Raphael, it has been excellent. We really appreciate your generosity, your presence with us today, and thanks to all of you for your presence here. This is going to come up at this webcast to be uploaded later today or tomorrow. Again, thank you, Raphael.
Thank you.
Thanks, and we'll keep in touch. Bye.